Welcome to our session today. It is November 1st, 2024. For those of you here live and for those of you watching it, it is almost winter time here in British Columbia. And it is my pleasure to welcome you to our session, Cultivating Sexual Health and Intimacy. Who doesn't want to talk about sex? That's what I want to know, because this is really, really one of the most interesting topics to pretty much anyone of any age. I'm Esther, and I'm the founder and CEO of Mind Myself. And I have three phenomenal physicians with us today who will be sharing about this topic and sharing from their vast experience. And a few housekeeping items before we get going. One, the vision of Mind Myself is to cultivate unity in times of divisiveness. I'm sure we've all experienced some of that over the last few years in particular. And our goal is also to help you become your own best health advocate. Really, to help you become your own best health advocate. And I want to thank you to all of you who've shown up today and who are listening after the fact. And thank you to my team for all the support that I get on a regular basis. And I want to respectfully acknowledge the traditional land stewards of the Katsi, Coquitlam, Kwantlen, and Kakite First Nations and their ancestors, on whose lands I live, work, and play, and whose waters I drink. This land is also now known as Surrey, BC, in Canada. And no event like this would be complete without a disclaimer, so here we go. All the information and advice for Mind Myself and the practitioners is for general education purposes only and is not intended to be substitute for professional medical advice, diagnosis, or treatment. The information here and on the Mind Myself website should not be used to self-diagnose or self-treat medical conditions. We always recommend that you consult with a doctor or other qualified healthcare practitioner for individualized medical advice on specific medical issues. And the views and values of each practitioner do not necessarily reflect the views and values of Mind Myself. A couple of quotes to get us started. Intimacy is more than physical. It's about connection, communication, and mutual respect. With yourself first, and then with your significant other and others in your life. The idea that we have become invisible after a certain age is a myth that I refuse to buy into. We have every right to feel vibrant and sexy at any age. And just before we introduce the practitioners as they introduce themselves, I want to say we welcome different opinions. We have three very powerful physicians who've had their own unique practices over the years, and they may come from slightly different perspectives. I think that's a good thing because that helps us make up our own mind from our own perspectives as well. We will also be experiencing cultural diversity. We have people from all over the globe here today, and our practitioners are as well. So we welcome that. And as we get going, let's just take a couple of breaths together. Feel your feet on the ground, lengthen your spine, and let's take a couple of deep breaths together. Just inhale and hold it for a moment, and then exhale. And let's do that twice more on our own timing. Great. I feel centered and grounded. I hope you do too. And I am going to have the great pleasure of welcoming our three practitioners. Please introduce yourselves one at a time. And let's start with Dr. Neelima. Can you tell us a bit about yourself, your background, and what makes you so awesome? Because you are, all of you.
Thank you very much, Esther. Thank you for having me. Um, I'm Dr. Neelima Deshpande. I'm based out of Pune, in India. I did my qualification in OBGYN from India and from the UK. and I've worked pretty much all over the world, including countries like Bhutan. Um, my specialty is menopause, sexual and reproductive health, and my background is in urogynecology and pelvic floor dysfunction. So I've published a book as well about menopause, and I run the menopause track with WildFit. So my belief is about holistic well-being in relationship to menopause and improving symptoms that way rather than medication.
Thank you so much. All right, Dr. Vicky.
Hi, and thank you, Esther, for allowing me to be a part of this panel. I am Dr. Victoria Monlock. I am in Waukesha, Wisconsin, just west of Milwaukee. I retired recently, but had a 35-year career in OBGYN and added complementary alternative medicine, regenerative medicine, and energy medicine to my practice. My focus was initially women only, and I did consented research on my patients to develop the curves for where age appropriate hormone levels at all ages of women's health need to be for optimal health. And a men's book is coming, but my specialty is women's health. My two books focus on adolescent health and on perimenopause, menopause, postmenopausal health.
Thank you, Dr. Vicky. Dr. Sue Lin.
Hi, thanks for having me. I'm excited about our day today. And I'm a urologist trained in New York. I've been in private practice for 25, 26 years. And then I actually practiced in Kansas for that time. And then came to Arizona, to the University of Arizona as an associate professor here. And now I'm author of a book coming out hopefully soon on sexual health, male sexual health, on how to get ahead. And I trained in functional medicine, and so I'm an owner and practitioner at Quantum Health and Wellness Center, where I focus on hormone replacement therapy, but then also on holistic health about mind, body, soul. I had also had massage therapists. I had people working for um, float therapy, and so that we could get all our bodies involved in mental, physical, and emotional well-being.
Fantastic. Thank you so much. Now, we have a series of topics that we're going to cover, and I may mix them up. I know that I gave them to you in a particular order, but I think one of the things that we should start with is how is sexual health a part of our regular health, our general overall health? Dr. Vicky, why don't you start us off?
Thank you. Well, and in particular, our sexual health is a vital part of who we are, but realize that our sexual health is governed by our physical health. And so if we are not in optimal health, and some people will be, some people won't be, but if you have that perimenopausal time of sawtooth female hormone levels, you're going to have variable desire, variable libido, variable risk of could I get pregnant? I don't know. If I want to make certain that I can have intimacy without risk. And so there are several factors that go into whether or not people feel comfortable keeping their sexual health as part of their overall health, because that's going to change over time. And so it can be kind of a scary time for a lot of women in perimenopause and heading into menopause because they're not certain what their hormonal picture is month to month to month to month. And menopause, it may be a very much more discomfort with sexual health. And so that's a scary thought. There may be other issues that go on, like pelvic floor dysfunction, pelvic floor falling, pain with intercourse due to dryness. There are several factors that come into it, but your overall health is governed by your mind, body, spirit. We have to feel like we are worthy of being able to keep sexual health a part of our regular health. So there are many components and it's variable.
Thank you so much. Dr. Sue Lin.
Yeah, sexual health is equal to overall health. They're totally related and they impact each other. You actually, if you don't feel well, if you have a chronic medical condition, it affects your feeling of well-being, your ability to give of yourself, to be enticing, and to feel good about yourself if you're not healthy. If you have chronic pain, if you are not interested, you won't be interested in sexual health if you're not feeling well. So our overall health is completely related. If you're anorexic, if you're obese, and you don't feel good about how you look and how you feel, it totally impacts our sexual health as well. And hormones, as we are excreted each day, and as we age, that totally impacts how we feel, because if we're decreasing production of specific hormones, such as estrogen, progesterone, testosterone, that affects sleep, mood, irritability, health, sexual feeling, ability to perform, and in men, definitely for erections, for women, vaginal dryness. So it's definitely impacting both, and they're equally effective.
Thank you. Dr. Nilima.
Such excellent points, both by Dr. Victoria and Dr. Sulan. Really wonderful. I wanted to add a little bit in the sense that with the World Association for Sexual Health, we now talk about sexual dysfunction or sexual problems as being part of a biopsychosocial cultural um, phenomenon. So any problems we experience in our sexual lives are actually a much, much bigger entity. So when we optimize our physical health, but we don't optimize our social cultural interactions, then we suffer. So this is particularly important as we age, because across the world, and particularly in more conservative societies, older women, older men enjoying sex, enjoying romance, intimacy, feeling desire, feeling the delicate sensations that orgasm brings, the benefits of orgasm, these are not really supported. And we need to consider that whenever we are managing ourselves, when we present what we want, what we don't want, even when we talk to physicians. So it's an important point to keep in mind is being aware of the social cultural context of our sexual lives, which is part of our overall well-being. If we don't have good social connections, we're very unlikely to be healthy anyway. Our health is also determined by the company we keep.
I love that. Our health is determined by the company we keep. Well, we're in good company today, that's for sure. Let's talk about changes in libido. I know that you all three have referred to little bits about that, but Dr. Neelima, you're on a roll there. Talk about libido as we age and how that changes.
Absolutely. I have a slightly different perspective. And again, coming from the European Society for Sexual Medicine and the World Association for Sexual Health, our understanding of libido and desire is slightly different. So libido is in the context of, say, a hormone like testosterone, which determines our drive and the thoughts that we have about sex, about intercourse, about attracting a mate, about being attractive, about using our bodies, our thoughts, our feelings, and our behaviors to attract a partner, sexual partner. As testosterone declines, testosterone and estrogen and progesterone, all of these are on a decline, but they swing, like Dr. Victoria talked about the sawtooth method. They're swinging up and down, but overall there's a decline. We might experience changes in the quality and the quantity of these thoughts, and that's what's reflected, what we call as changing libido. Desire, on the other hand, is much more about intimacy. It's more about building connection. And this is more a female perspective. So men often will talk in the context of, oh, partner seeking or actually looking for sex, looking for sexual interactions, whereas women talk more about connection. And that's where the desire comes in. So desire is more in terms of forming a bond with somebody that you may or may not be interested in building a sexual relationship with. But it is often talked about in the context of sexual relationships. And we find that as we age, both libido and desire may decline, but it's not absolute. We know certainly from research that women who enter their menopausal years can feel just as much desire for connection, intimacy, closeness, and feeling uplifted with being sexual with somebody as younger women do. They may not experience the same frequency of sexual thoughts as testosterone declines. Many times when testosterone is prescribed or medicines, like, the medicalization of female sexual health is something that's talked about a lot. And we'll be talking more about that as you discuss those kind of medicines. And especially Dr. Victoria and Dr. Sulin will also talk about those medicines. But the whole thing to understand is that female sexuality, including desire and libido, is very, very complex. It's not as straightforward as men's is. It's very complex. And again, it's determined more by this biopsychosocial cultural environment that we're in. And that affects how we display our interest in our libido, our desire for connection, the kind of mates, the kind of partners you choose as you go through these changing years. It's affected by financial status, work, by reflections of partners or friends and how they comment upon your choice of mate. And sometimes it's a reflection of our self-esteem and our status within ourselves. So again, the way Esther mentioned about our relationship with ourselves is actually much more important in these years than it was ever before.
Thank you, Dr. Nilima. Dr. Sulin.
Yes, libido actually is a driving force, as you said, in regards to testosterone. And as I'm a urologist and treat so many men, men actually start decreasing their testosterone production in their 40s and 50s, and women actually decrease testosterone production in the 30s. So a lot of women that think, oh, my libido's decreased because the kids, I'm tired, I'm working all the time, actually their testosterone starts declining, and they actually may need testosterone replacement to improve their libido. Thyroid also has an impact on libido. And so sometimes if your thyroid is not optimized, that can have an effect. But lately, I've been seeing a lot of young men that have libido issues. And the problem is our current such a big exposure to Instagram and to all these social media avenues, guys are having unrealistic expectations of their ability to perform. And they have issues as young men. In my testosterone clinic, I see patients from Arizona, Florida, Kansas, all having problems even in their 20s. That's crazy. We never used to see, as urologists, men having issues with libido or erections until they're over 50s. And so that is a new thing. So there's a huge psychological component for both men and women. And even alcohol plays a major role. For women, it may relax them more and let them forget about all the bills they have to pay, all the children they have to take care of. But for men, it actually may decrease their ability to have a good erection. And it may be not just a physical component, but also a mental component associated with this decreased libido and decreased ability to perform.
Thank you, Dr. Sulin. Dr. Vicky, I'm sure
Well,
you have a perspective here.
Thank you. I come from the research that I did with my patients for 20 years. And it's different for women than men. That libido in women is actually more tied to estradiol loss. When I'm checking levels, especially in late perimenopausal, menopausal women, I'm finding their testosterone levels are a higher percentile than their estradiol levels. So it's not a low testosterone in women driving low libido, it's actually a low estradiol. And so if we put that in proper perspective, libido then in women is driven by female hormone, and that really should be no surprise. And in men, yes, is driven by testosterone. So in particular, what needs to be recognized is that estradiol and replacement of proper amounts of estradiol, whether it's done vaginally or whether it's done systemically, is something that's hugely important to libido. In a male setting where, yes, I was seeing men in their 30s, in fact, a male that was 34 walking into my office saying, Doc, not only am I having some trouble with my erections, but I am so bone dead fatigued. I come home from work and I fall asleep on the couch. I sleep through dinner. I sleep through the evening. I go to bed. I get up in the morning and I'm just as tired as when I went to bed. What is wrong with me? And, my comment is it's low T. And we'll check it. And sure enough, it'll be age inappropriate because there is a gradual decline in men in their testosterone levels over time, but they never lose their testosterone production like women lose their female hormone production. But the dirty little secret for women to know is that our ovaries stop making estradiol progesterone, but it never stops making testosterone. So we're actually in menopause, women become men. Whoa, wait a minute. What do you mean? We actually physiologically become more male in a chemical pattern. So why do we see decreased libido being called a low testosterone problem? It doesn't compute in my mind when you look at the whole picture. And then you also have to realize female male hormone is one of the four foundational hormone groups that needs to be looked at. So you have to look at cortisol, which is stress. You have to look at insulin, which is relatable to diet and exercise and lifestyle. And you have to look at thyroid as well. So all four of those main foundational hormone groups have a part to play in balancing what our female male hormone levels also do.
Thank you so much. And let's talk about specifically for women, menopausal symptoms and perhaps some of those, the physical discomfort and pain during sex. Dr. Vicky, you're on a roll there. Let's talk about that.
Well, the symptoms are long and distinguished. And they're in my books, but in particular, there are estradiol deficient symptoms that include everything from short-term memory loss to dry skin to increased migraines to increased acid reflux to bladder incontinence to low libido to muscle aches, joint ache. There are symptoms that go from head to toe, and you go, well, that's crazy. But if we stop making estradiol, you have to realize that estradiol, its role in the body is to increase blood supply per square inch to organs that have estradiol receptors, which begs the question, which organs have estradiol receptors?
Everything.
Spoiler, every single one. So literally from head to toe. Wow. So then there are symptoms that are more progesterone deprivation symptoms. All of your moodiness and being angry and being quick-tempered and abdominal symptoms like bloating. Those are the women that come in and say, Doc, I eat 2 bites of a meal and I have to unbutton my pants because I'm bloating. What is wrong? I can't function this way, and I can't just buy a new wardrobe at that time of my cycle, or now that I'm menopausal. I just can't do that. I want to stay in my same clothes. It has a lot to do with breast tenderness, believe it or not, and that ties also with estradiol. Testosterone in excess are things like losing hair from the top of your head, gaining hair where you don't want it, perhaps even shaving, having that dreaded mid-abdominal weight gain. Nobody wants an extra 5 or 10 or 15 pounds. So goodness gracious, besides bloating, now we're putting that on because we're male. That testosterone dominance in a menopausal woman puts that weight right where we don't want it and can't get it off, even though we're doing the same exercise, the same diet. So we truly need to know that there's a need to stay on top of what your hormone levels are, on top of what your balance of your hormones are, because you don't want any of those symptoms. My list of symptoms is about 40 to 50 long, and people would check mark them and circle them so hard because they're angry at those symptoms, they would tear the paper. And I would say to them, give me your top 3 symptoms. And I would say to them, okay, if I can get rid of those top 3 symptoms in the next 6 months for you, would that be okay with you? Boom. Wow. And it's as simple as knowing their hormone balance.
Thank you, Dr. Vicky. Dr. Nilima, you were going to jump in there.
I'm not jumping. I was just agreeing with
No, no, no,
everything she
no.
was
I love
saying.
it. I love it. I love it.
It's fun. I think our bodies are so magical, and the hormone balances and the stories they tell us and the way they draw us into various kinds of things is it's magical. But the body is a fine thing. Menopause is a gift. We weren't supposed to be here. If you look at evolution, our roles pretty much, you lose your evolutionary advantage once you cross 65. So the gap between 35 and 65 is the one that we need to cross and need to cover in a way that it gives us what we want from life. It gives us a perspective that there's life still worth living. There's something more out there for us because we've got the privilege of still being around. When you're in pain, when you're in discomfort, when the brain doesn't work like it's supposed to, when there's brain fog and the vagina doesn't work and the nipples are not as sensitive and the skin feels crawling with insects rather than, with tingling and desire, then you start to question your body and your own sanity. And that's what a lot of women experience as they start to go through menopause. Am I going mad? Is something wrong with me? And one of the most important perspectives is that there's nothing wrong with us. There never was. This is part of our evolutionary journey. It's part of what's meant to happen. We just have the privilege of being able to experience it in the times that we live today. Then comes the question of optimizing this transition period. So we actually get to live our lives because our lives are very complex these days. We don't just get to hang around with other women and laugh and cuddle grandchildren. We actually have to earn, make a living, contribute, think on our feet sometimes really fast, deal with emergencies, care for elderly people, be part of a community, contribute, experience growth, vitality. There's a lot going on, and it's not something our bodies were designed for. So understanding the role of stress, exactly like Dr. Vicky said, understanding the role of our diet, our exercise, how we interact socially and culturally makes a big difference to how we experience these symptoms and the role they play in our sexual expression and sexuality. When we think about things like vaginal dryness, pain, and discomfort, it's very easy to assume that's the only thing that puts us off. It's not just the vaginal dryness and pain and discomfort. It's the experience within the body. So the fact that your body doesn't respond the way it used to, the fact that your brain doesn't function the way it used to, what you used to find attractive is no longer attractive. Suddenly you're with the same person, but you find the smell offensive. Your sense of smell changes. Your understanding of music may change because your hearing is different. You just don't like the noise anymore. You don't engage in the quarrels in the same way. Or sometimes you can get in a rut. The grumpiness, the irritability, it can become a bad habit because it goes on for so long. And that makes it difficult to live as an older woman because you end up alienating the very people you need to support you. So how do you get your head around it? Well, one of the most important things as we go and look at menopause symptoms is to understand that we can preempt a lot of these problems by understanding them, getting knowledge, being educated like we are today, and actually playing an important role in our own health and well-being, particularly our mental health and well-being, and seeking help where we need it, whether it's with hormone replacement therapy, psychotherapy, with relationship challenges. Maybe sometimes what you need is a financial overhaul, to get your finances in order, because we know from research that having poor finances can be a big drain on relationships, can cause a lot of quarrels and discomfort, and sex then just gets put aside because who cares about desire, right? When you're worried about your bills or you can't pay your school kids fees or whatever. Children, teenagers going through puberty symptoms at the same time as we're going through menopause symptoms, that can be a real challenge. I mean, as it is, you've got less bandwidth in your brain. My dad used to say to me, "You don't tolerate stupidity very much, do you?" I said, "It's getting harder. It's getting harder." But imagine dealing with a teenager and their strops and tantrums. It's going to be really difficult. So preempting all this is skills that we need to get along the way. And sometimes if you don't know, it can really hit you, particularly things like depression. The 30% of women experience depression for the first time at menopause, and I've lost two friends to suicide. The fear of cancer is big, diabetes, hypertension. I've lost friends who died in their sleep. They weren't expecting it. So waking up is a privilege. And I don't think we realize we don't give it that much importance, understanding that we're around, we wake up and we get another day. And we should make the
Thank
most
you.
of each day.
Thank you, Dr. Nilima. That's awesome. Dr. Sue Lin,
So
add,
true.
add
So
to this
true.
mix.
Actually, it's so complicated. Actually, in my book, I actually write about how stress and cortisol and all those things affect our sexual health and how financial is a big component to sexual happiness. Because hormones are responsible how we feel, how we look, how we perform, how we function, right? Our pituitary gland in the brain tells our thyroid what to do, which controls heart rate, blood pressure, right? Temperature. And then our adrenal gland is where most of our hormones are actually made. Everybody thinks that the testicles produces all the testosterone and the ovaries produce all the estrogen. Well, no, it's actually made in the adrenal gland, which is right above the kidney. So when I take a kidney out for kidney cancer, I make sure I leave the adrenal gland because it's the breakdown of cholesterol that provides the breakdown to progesterone that creates estrogen, testosterone. But the main thing, cortisol, which is the only hormone that increases with age, that is the hormone that steals everything. Stress steals testosterone. I have a lot of soldiers that would come back from Iraq and they're 20 years old and their testosterones are 200. That's crazy. Why would that be? Well, they're being shot at, they're eating MREs, they're away from family. Who's more stressed, right? And you would see a 20-year-old who should have a testosterone of 1,000 and they'd have a testosterone of 200. That's crazy. And that's because cortisol, which is the stress hormone, steals testosterone. It also steals progesterone. That's why us as women have trouble sleeping because progesterone is huge for mood, irritability, sleep. And the ratio of estrogen to progesterone should be 8-1. And so when we have estrogen dominance, you have too much estrogen compared to progesterone, you have weight gain, anxiety, headaches, decreased libido, right? As I said, testosterone starts decreasing in our 30s. Estrogen starts decreasing between 35 and 50 by like 35%. Progesterone starts decreasing by 75% between 35 and 50. So this affects our natural milieu in our bodies, which you asked about discomfort with vaginal intercourse. That's a big thing in regards to dryness and pain resulting from estrogen, but then also if the tissues are not able to be compliant, it also affects what? Stress incontinence. As a urologist, what we do for stress incontinence many times leads with estrogen. Well, that helps vaginal as well when we treat both, because what happens with stress incontinence, which many women experience, the urethra is not able to be as compliant. And then when we leak urine and we have discomfort of wanting to have sex, and we have many other things. But there are other treatments available, including estriol vaginal cream. We have the Mona Lisa touch, which is a laser for the vagina that makes holes in the vaginal mucosa, makes blood vessels grow in, and can help with the discomfort. So we have lots of things to treat women that have this problem. They just have to be aware this is not a problem. It's something that we're able to address and fix and make them more comfortable to be able to enjoy menopause.
Thank you, Dr. Sue Lin. We've talked a lot about the physical aspect of sexuality and aging, and we'll probably get to some more of that. But let's talk about the intimacy side of things and how do we navigate intimacy after life transitions? And before we answer that, and Dr. Sue Lin, I'm going to start with you. Let's all take a little stretch together and move because we've been sitting for half an hour or so. And it's very important. You can stand up, do something that feels good in your body, and then we'll come back. Take a sip of water. Hydration is super important. We want to mirror our values here in what we're doing. Awesome. So navigating intimacy with all of this stuff going on physically. Dr. Sue Lin, make a few short comments here.
Sure. So our physical pleasure is an integral part of sexual health and body confidence. And our physical nature and how we feel about ourselves is very important. And navigating through pleasure, becoming more in tune with our bodies and how they work is a crucial part for self-esteem, body positivity, and in intimate relationships, understanding how pleasure works is on a physical level is very important for both partners to be able to communicate openly about their needs and desire. And so it's very important that our physical act of intimacy, when practiced regularly, actually helps to maintain our healthy hormone levels and supports our cardiovascular as well as our muscle tone by increasing even our pelvic floor strength. That will actually help with navigating our intimacy component to the physical and emotional component that's attached with that.
Fantastic. Thank you. Dr. Neelima.
Absolutely. I totally support that. Intimacy comes in many different ways. And as we age, it's important to understand that couples go through phases where they have physical challenges. So one or the other couple may be facing health challenges. They may be facing situations at work or with their other, like, for example, I am looking after my parents, elderly parents. You may be a caregiver to somebody, and that poses a big emotional drain on you. Now, as you're experiencing all of these different roles, making time to be intimate, to give it priority is something that a lot of couples forget to do. They get caught up in bringing up children, in building a business. They get caught up in engaging social culturally, maybe with work colleagues, but they neglect their partners. They neglect to feed the relationship in the same way as they would feed all other aspects of their life. And intimacy is something that needs cultivating, it needs investment, and it needs awareness of stuff that's changing. Because as we age, both men and women, as we age, our bodies change physically, but our mindsets also become a lot more fixed. And when I talked about being angry and irritable and getting into bad habits, we do that a lot more easily with our intimate partners because we know their triggers. And it's not just us triggering ourselves. We actually misbehave because we get away with it. And that is a real killer for intimacy because it erodes trust, it erodes respect, and it erodes power. When couples start engaging in power games because they're trying to adapt to their changing health situation, maybe to their changing dynamics at work or on an interpersonal level, then it affects the way they engage with their partners, how openly they can communicate, how much vulnerability they're willing to bring to that relationship. When vulnerability suffers and the relationship becomes a power struggle, then intimacy suffers. When intimacy on many levels, whether it's intellectual, physical, experiential, all these different kinds of intimacy suffer, then sexual intimacy suffers because we're most vulnerable when we're sexually intimate with somebody. And many of us have had the experience where you just one look or one word can destroy many things. It can really, really change your day. And women are much more complex than men. Men are able to compartmentalize where women can't. They often don't want to either. So many different things affecting intimacy as we age.
Thank you so much. Dr. Vicky.
Well, and again, intimacy, you're right, is extremely complex. One of the things that we said to each other when we first got married, and I went right into medical school, was we need to have date night once a week. You're busy, I'm busy, we need date night once a week. It's inviolable, nobody can touch it. And we made that vow to each other. And there are times when it will backfire. I'll tell you a quick little story. We were having our intimate moment, and my oldest daughter walked in on us, and my husband was having a harder time than I was, but I could immediately switch gears and go, "Hi, sweetheart. What can we do for you?" As we're in an obvious embrace of more than just embracing. And she asked her question and then had the add-on question and then the third add-on question. And meanwhile, the mood kind of got lost and everything else got lost. And when she finally had her questions satisfied and she walked out of the room, I looked at my husband and I said, well, that's a mood killer. Uh, but it took us about, oh, maybe 6, 7 years after she went off to college and whatever, that this story came up, and she was mortified that she had walked in on us and had no idea that that had happened. But it didn't quell date night. In other words, date night was still important. And the whole idea of, and I can agree more with you, Dr. Neelima, that mutual respect of each other, taking, even as partners, taking each other for where we're at, not taking advantage of a situation maybe going on at work with somebody. But again, going back to the physical, women's bodies change. It's hormone driven as our hormones change. We're not always in control of that 5 pound weight gain. We may be derided by our partner. Well, that dress looks tight on you. You better go change. We're going out, and the implication is I don't want to be seen with you unless you look good. The eye candy aspect of who's hanging on my arm, and you have to look right. And the same with women, they want somebody that doesn't have, a beer belly hanging out, and that they might look like they've never gone to the gym in the past 2 years. So we are a very visual society. We have to kind of realize that some of that has been put upon us from external, but what is our internal relationship with each other? And what are we considering important? And if we consider our health important, if we consider each other important, then really intimacy is a natural flow from that because there's mutual respect.
Thank you, Dr. Vicky. And what occurs to me as I'm hearing such great information from you, we could talk for hours and hours and hours. Absolutely. There are lots of women and men, or people of whatever gender, that's a whole other conversation, but as single individuals, or individuals in a marriage of convenience, or an arranged marriage, or in a marriage that's just maybe not as close and intimate as it has been in some capacity. And I know we've touched on that, but or somebody single by choice, or maybe not by choice. Let's talk about sexuality and singleness or aloneness. Let's call it aloneness, no matter what state you're in. Let's have a conversation about that. Dr. Neelima, do you want to start us off? And you're muted.
I've got Diwali firecrackers going on. That's why I
Okay,
muted
well, listen to
myself. Um, as someone who's been single almost most of my life, I'd say that yes, loneliness rather than aloneness is what disturbs a lot of people. I'm quite happy to be alone. I don't feel lonely or deprived because I'm alone. What gets to a lot of my friends who are also choosing to be single is the fact that they don't understand how to negotiate, persuade, how to engage with a completely different species, which men are. Just going back to men are from Mars and women are from Venus,
and
because
they
our
think we're a
brains,
different species. Yes.
yeah, well, we're mostly women here, so we talk it as us and them. The difficulty happens because our brains are different, because we're exposed to swinging hormone changes very differently to men. Men are used to having steady state hormones throughout their lives, pretty much until it declines. And even in men, when testosterone declines, it doesn't swing. It goes at a steady, gradual decline. So they have no understanding whatsoever that a woman's brain is actually different in the morning to the evening. Her brain can change looking at food. The way she looks at food in the morning can change by lunchtime. It can change by dinner time. And, in our session on breasts, we talk about how, the bra design is different because your breast size, how your breasts feel can change between morning and evening. Forget about just your cycle, the beginning, the middle, and the end. So actually, a woman's brain is complex. We don't negotiate. We don't have conversations. We're not designed in the same way as men. And we are put in an evolution gap. And Eric talks about this a lot, Eric Edmeans, where we are forced to live in situations where men and women, or when we are men and women, when we're not just women and women, because women and women get on much better than women and men do, and men and men get on much better than women and men do. But when we're cohabiting in a nuclear family situation, it's unnatural because we were never expected to just live with each other for most of our lives. We were meant to be in tribes. We were meant to spend most of our time with women and then come together, procreate, and then go back to being with women. So in this complex situation where we're forced to understand each other, we're forced to have a conversation where we actually understand the other person's perspective without feeling threatened in that relationship, and understanding that for men, safety, security, etc., is not as much of a priority as it for women, because women's priorities are in their reproductive years about children, childbearing, protecting the family. And as we go into menopause, it becomes more an issue of survival. As evolutionary women who are looking at aging and loss of vitality and the fears of aging and needing to be looked after. Women fear being alone a lot more than men do. And then that brings us to the perspective of aloneness, loneliness, and the fears it brings to women much more than it does men. That's not solved by just being in a relationship. Women need to be much more empowered.
Thank you, Dr. Neelima. Dr. Vicky, do you want to comment on your perspective of what single women do, or women who are alone, even in a relationship?
Well, having had all of three of my daughters decide to enter a relationship later in life, it has been an interesting ride to hear what all three of my daughters did as they answered that question for themselves. And one of my daughters was military, so she was around men more than she was around women, but not in a relationship standpoint, in a workplace camaraderie standpoint. And it was very much a intellectual competition that she would go into, and she put most of her effort as intellectual competition and then performance. And that was kind of her, I don't know if you want to call it her substitute, but it was something that occupied a lot of her day, and she felt less need for a physical relationship. And I think that's quite common in the military. My second daughter was very focused on getting her advanced degree and the research that went with getting an advanced degree. And that meant interacting with her female principal investigator, but other males in the lab. But it meant in a working training situation that there was equal exposure, but the majority of her, if you will, example came from her principal investigator as a female. And so she was able to at least have an equal exposure, if you will. But it was parlayed on how much time do I have to devote away from what I need to learn and do in my academic setting. Do I have time for a relationship? So it became something that she chose to put on a back burner. My youngest daughter was, and the youngest is always the most interesting in every family, was someone who actually educated me on, Mom, don't you know about some of the sex toys that are out there that can be very satisfying for women to use? And I just went, because I'm hearing this from my daughter, and it was not what I expected to hear. And she was my first of my three to get married. And it was interesting that she was coming at it from the physicality standpoint, not so much the intimacy standpoint, because to her it was the physical that meant something to her at that stage in her life. And so I think that's also a fair question. Do we need more physical when we're in higher hormone levels? Does that change as we go forward? Does it change orgasm? Does it change our response to our partner? And that drive, that libido impact on our physical performance does change from youth through middle age to menopausal years, and what that change in intimacy and performance therefore looks like.
Thank you. Dr. Sue Lin.
Yes, as per Rupi Kaur said, how you love yourself is how you teach others to love you. So I feel like there's a whole spectrum of women that need building and maintaining self-esteem, and that's truly an inside job. We have to love ourselves the way we are and how we do things to be able to give love and give of ourselves. So learning how to please ourselves, even emotionally, physically, it requires knowledge about it, about self-acceptance, about willingness to experiment even. But insecurities arise out of fear. Some people have had trauma growing up and need someone else to give them confidence so they don't feel good alone. But actually, you really need to be within yourself, indulge in your own healthy eating, in your own intentional practice, in your own, creating a spa even in your home if you can't afford going to a spa, your own inner growth and contentment in your style and your way of showing up in the world, huge. I think that you have to value yourself first. And as a woman, you have to see the same in others. And external validation is great, but you have to have your own internal self-worth.
Thank you, Dr. Sue Lin. And I think that segues beautifully into the whole conversation on shame and stigma around women's sexuality. Do you want to keep going on that and explore that topic a little bit?
Sure. I see a lot of women that have stress urinary incontinence, and that is actually much more common than people realize. Most women that have had vaginal deliveries or have had even women that have not had deliveries, when they become postmenopausal, the urethra changes, the pelvic floor changes. And as a result, when you start leaking urine, you have to wear a pad, you feel uncomfortable, you feel, you have to know where the bathrooms are. And that creates shame. Shame, even that one of my patients said to me, I can't even go without panties in my sexy dress to go out to, feel sexy with my husband because I have to wear a pad. And wow, you never think of that shame as being a physical shame, but it can be an emotional shame when it becomes physical in something just as simple as urinary incontinence. And it is much more prevalent than a lot of people realize. And leaking urine, you may feel, difficult, uncomfortable with oral or vaginal sex, and your body image changes. And so shame in regards to if you've gained weight and you're not comfortable with the weight you've gained, you don't feel physically good because as we age, our boobs droop or abdominal girth increases, we get varicose veins. And so if you are not feeling good and feeling shame, or shame even from trauma, if you were abused as a child or abused as an adult, that brings a whole nother level of shame that you have to get beyond to be able to feel good about yourself. And so that's a big component, even with intimacy.
Thank you, Dr. Vicky. Thank you, Dr. Vicky.
Well, and to add to that, from a pelvic floor relaxation standpoint, what also can happen is that there can be a rectal hernia, that the actual act of intimacy and intercourse can actually cause stooling. And there is nothing more embarrassing than stooling in the middle of an intimate act, or even having your bladder leak with each thrust. And that is just a devastating mood killer. But how do you then approach the next time you want to be intimate with that same partner? That memory doesn't go away. And so the ultimate shame is, why don't you fix this? And you didn't realize this was something that you had to go to that level to fix, because it may mean a procedure. It may mean that I don't have time to take off work to do something like this. Isn't there something quick I can do? And, especially in a breast cancer patient, there may be fear of hormone even vaginally, despite a practitioner saying, yes, you can safely take some hormone vaginally. It won't impact any breast cancer treatment or recovery, but the patient may have a hard time coming to that same understanding. So there are many issues that could happen. And you're right, Dr. Sulin. I've even had nuns who have never had a sexual relationship have pelvic floor incontinence. And you'd say, well, gee, this isn't from having had a baby. This is simply from having estrogen levels drop without being replaced, that their pelvic floor just drops right with their estradiol levels. And I had one patient, it actually was very early in my practice, who walked in and she said, I don't know what to do. We can't have intercourse. She said, and I have a hard time voiding and I have a hard time having a bowel movement. And I said, well, let's do an exam. She didn't allude to anything at all. When I got her up on the pelvic table and I walked in the room and went to do her pelvic exam, her entire vaginal vault was externalized, which meant her bladder was externalized and her rectum was externalized, but covered with the vaginal tissues. So it was down halfway to her knees. And there was an ulcer on the bottom of that vaginal cuff, which normally is way up on the inside. And I said, well, you were concerned about having intercourse. I said, but tell me, how do you empty your bladder? She said, well, I make a fist and I put it on the bottom of this sack and I push it back in and then my bladder can empty. She said, but when we try to have sex, my husband isn't big enough to push the whole thing back in himself, so we just don't. And I thought, oh my word, how on earth have you been functioning? How do you buy clothes when you have something that is halfway down to your knees? And then there was this ulceration there. And I remember saying to her, well, we have to do something to fix this. And she said, but if I'm okay just pushing it in, isn't that okay? I said, well, in very short order, you're going to meet every dog in your neighborhood. And she went, excuse me? And I said, well, what's behind this ulceration and this very thin amount of tissue that's left is actually your GI tract and your bowels. I said, so at some point, what's going to happen is it's going to break down and you're going to trail your entire GI tract in back of you when you walk. And she just started laughing, but she understood what I was trying to say to her. And she said, all right, all right, all right.
There's so many treatments.
Yeah.
Yeah.
And
So
hopefully
many
that
treatments
extra
available.
exactly. Hopefully that extreme situation will not apply to anybody here or listening to this later. But there are solutions, people. You do not have
Yeah.
to have that happen to you. Oh my
We
goodness.
can do
I
we can
was
do pelvic surgery to tuck everything up, and we can do estrogen to clean everything up. That's so true.
it was just somebody who had neglected seeing anybody medically,
Yes.
obviously, for years.
Wow.
But
Yeah.
obviously, that is still a situation that could be out there, and we have to be
Right.
aware that
Right.
there is that level of fear and shame of I can't even present myself to a doctor because I let it go too far.
Right. So it's
I've
never
seen
too
that.
late, but let's go earlier. Dr. Dr. Neelima, how about shame and stigma in female sexuality from your point of view?
I come from a country where the Kama Sutra was gifted to the world, where sculptures we visit have erotica specifically to educate the public. But I also come from a world where talking about female sexuality, female sexual needs is taboo. The fact that a woman might actually think about sex and might want herself to be treated differently, or want sex to be offered differently, or want intimacy or pleasuring to become a priority is almost unacceptable as a request. They're literally secondary citizens. By female sexual dysfunction is not treated as an important subject in medical school. It is not taught to doctors. I know many OBGYN specialists here in my city who would quite happily just cut a hymen rather than treat somebody for vaginismus, a condition where the pelvic floor is very tight, where sex becomes difficult. I've had a patient couple come to me recently. The lady had early, stage 4 carcinoma of the rectum. She's only 34 now. This was 2 years ago. She got diagnosed during lockdown. And the doctors she saw, they were like, oh, she's got stage 4 rectal carcinoma. We need to save her life. So they offered her everything, radiotherapy, chemotherapy. They tried to operate, but they couldn't. But they forgot that she's in a relationship. She has one son, luckily, but they forgot that she's got a partner. They forgot that she's a sexual being. And they didn't talk to her about the effect all of this was going to have on her vagina and her ovaries. Consequently, now she is menopausal with no hormone therapy. She has a vagina that's shut off because it's atrophied. Somebody tried to repair it, but she can't use dilators because nobody prescribed vaginal estrogen. The couple are left fighting. The only reason they're together is because they have a son. And they can't talk to each other anymore because they don't know how to relate without having intercourse. The childhood sweethearts, they were together, they've had a great sex life, but that's the only thing they know how to do in a relationship. They don't know what intimacy is, how important touch is, how important vaginal estrogen was, how important couple counseling is, how important relationship counseling is, and neither do their doctors. When I try to talk to the oncologist saying, this is something that's been neglected, you need to fix it, your team needs a sex therapist, it needs a counselor so that women like these are not left stranded without any help. He says, no, but we saved her life. But for what? What did you save her life for? And to assume that somebody does not want to be sexual just because they had cancer, in my opinion, in my eyes, is a crime. We are first and foremost sexual beings. We are. And in all places in the world where this is denied to women, then female sexuality and sexual function becomes a cause of shame, taboo, ignorance, and a very, very poor quality of life. It's unacceptable.
Wow. I see we're just after the top of the hour and we're going to move in our Q&A section, but let's take another stretch. We've heard a lot of things in those stories. Wow, powerful stories. And since we talked about touch, let's just touch somewhere in your body that feels really good, because we get to do that to ourselves, no matter whether we're in a relationship by choice or otherwise. And let's just feel how good that feels for ourselves. And as we come back, we're going to go into the Q&A. Yes, definitely. Take a sip of water. And I'm going to share my screen with you briefly to talk about our final event of the year, and then we'll come right back to this Q&A section. Whew, deep topic. Here we go. As we said, Mind Myself is all about providing events like these that are full of information and compassion. I'm hearing such deep compassion. And there are solutions. And we do want you to become your own best health advocate. Seek help, but advocate for yourself because you know your body best. And in our next event, which is on December 13th, and I know that Rusty's going to put the link in the chat for us, it's called Staying True to You, Deepening Your Purpose and Intention Even During the Holidays. I like to have something in December that prepares people, because sometimes this time of year can be one of the most stressful times, certainly in North America, of all. And there are so many expectations. And so we're going to talk about things like setting boundaries, loving yourself, understanding your unique gifts in the context of your family and friends, cultivating self-compassion in the face of expectations, etc. So many things. And we have 3 phenomenal practitioners coming to you for that. And if you choose to sign up today, it's a free event. You will get your spot reserved. And you will be entered into a draw for show you, is this beautiful, soft blanket that you will want to herkle-durkle in over the holidays, which is stay in bed a little bit longer than you might. It's just so comfy, cozy. And that is an $80 retail value. And I'm also offering off a 1-hour coaching session he happens to be my partner, Bill Chalmers, but he is a phenomenal coach. And I know Dr. Neelima is smiling. Can you just say 10 seconds or 15 seconds of how amazing Bill is?
Bill is amazing. I can't see him. Where is he?
Here.
Since being coached with Bill since February this year, I have grown exponentially. My life is completely different. My mind is different. I find myself living a lot more intentionally, purposefully. I'm smiling a lot more. And the main purpose was actually to find my purpose and to be happier. But I think being happier is a lot more important. Purpose happens. But Bill is most amazing, most supportive, kind, compassionate, and wonderful coach.
Thank you, Doc.
Priceless to know him.
Thank you, Dr. Neelima. So one lucky person is going to get a coaching session and put into a draw for both of those prizes. And I want to also acknowledge and thank our sponsors, Light Life Technologies. This is a harmonizer, and that was provided by Katharina Sperling. And definitely check out their website. They have some amazing things. They also have these rings, and they produce metal energetic tools. So you need to go and find out more about those. I will not do it justice. The Gift Basket Company and Spread the Love and Brandon Inc. Promotions have provided that blanket too. So we can do this only with the sponsors and supporters and attendees like you. So if you sign up today, that would be fabulous. And ways to stay connected and engaged with myself. We would love your donations. We have self-funded this game for the last 4 years, 2 years live. And so, of course, we would love your donations. Or we have 2 other organizations that we support. Blind Beginnings helps families and children who are sight impaired or blind around British Columbia. And Ways of Transformations is an African organization, and they provide period products to young girls and education. And this is so important. We take it for granted that we can just go to a store and buy these things. These young women do not have that capacity. And then, of course, stay connected in all these ways. And I know that Rusty's going to help me by putting those links in the chat. So we will do that. And we will come back now to our regularly scheduled programming, and we will begin with the Q&A session. Thank you very much, Rusty, for putting those in the chat. And I think we haven't addressed, and I really want to get to this before we have some of the other questions from our audience. You can either raise your electronic hand or put your question in the chat. Either way is good. And the first one is, what if we have health conditions? I know you've both alluded to some, but health conditions and medications, and how do those affect sexual function or as we age? Dr. Vicky, would you start us off with that?
Well, of course, and thank you. Yes, medications, because they're chemical, can have a very underlying but definite impact on how the physiology of our hormones are impacting our body. We tend to forget that pharmaceuticals, although may be necessary for certain patients, they are chemical and not natural to our body. So they can have interactions with especially our foundational female hormones and male hormones. They can have impact on our thyroid, on our cortisol, on our insulin. And if the medications are for diabetes, they are going to have a double impact on that entire insulin complex, because they're going to impact whether or not that excess sugar in your system or trying to bring it down is impacting inflammation. So just the mere fact of chemical versus natural is one thing, but many of the side effects of these medications are going to be that there may be loss of libido, there may be a depressive side effect, and they'll say that, well, that's our disclaimer, but that doesn't change the fact that you don't know until you take it whether or not it's going to impact you. And so the unfairness of a situation like that is you may need the medication. You may think you need the medication. You may not be told that there are lifestyle adjustments that you can make that may help you get off of or lessen a dose of a medication. And in particular, antidepressants that are doled out like candy to women when they may actually be going to their doctor for, I have symptoms of poor sleep and a short-term memory loss and abdominal bloating when I eat. If a doctor is uncomfortable with putting all three of those together as possible, let's check your hormones, their knee-jerk response is many times, oh, you must be depressed. Let's start you on an antidepressant. And all of a sudden, it's like you going in saying, I want to buy a hammer. And they say, no, we're going to give you something else. We're going to give you a light bulb. And that's going to be what you're looking for. Well, no, you know your body. And so when women are told by a white coat that they have a different problem than what they think they have and what they walked in with, being dismissed for their acknowledgement of their symptoms and not being able to properly advocate for themselves means, well, that's the white coat. They went to school for a lot of years. They must be right. I must be wrong. It must be that I'm depressed. Well, that starts the cycle then of being put on a medication for something you don't need. Well, then, of course, it doesn't work. So then, of course, they're going to up the dose, right? Well, then, if that doesn't work, let's start a second antidepressant. And that spiral down is just an inevitability in some women's lives that to stop it means getting off of some of those medications may take 2 years to wean people off of a medication that gets so ingrained in their brain that it just literally takes that long to come off and get rid of those effects. So there is very definitely an effect of medication, and in particular, certain medications that may be at play.
Thank you, Dr. Vicky. Dr. Sulin.
Yes, actually 50 million women reach menopause and 60 million men reach andropause. Many patients are put on antidepressants, anti-anxiety meds, sleeping pills, blood pressure meds, NSAIDs, and most of them really have hormonal imbalance. And it's scary that we're not, as physicians, checking this on a regular basis. In my urology office, yes, we check testosterone, but not until I went back and got my master's in integrative and functional medicine and learned more about nutrition, how the gut is important, and learn about preventative health. And one thing that we can do to reduce atherosclerotic heart disease, diabetes with our diet, that is much more important than giving just pills, because a lot of our pills that we're giving are causing other problems. So say you're having diabetes, not just the diabetes causing plaques forming in the wall of the blood vessels to inhibit blood flow for an erection, for instance, for our male patients, or for incontinence for our female patients. But actually treating the diabetes now reduces libido and effect on sexual function. So now you're causing one problem and trying to fix another, but you're not really fixing the cause. So a lot of times we're just checking and fixing the symptoms rather than the cause for these problems for most patients. And say somebody who has hypertension, changing their diet is huge. Learning about nutrition, learning about what they're eating, or what's your gut health, what's causing your inflammation? Is it environmental? Is it diet related? And a lot of us that have developed insulin resistance as a result of all the high fructose corn syrup that's put in our diet are now taking things like semaglutide. Yes, I treat patients with semaglutide to help them lose weight. Yes, their cholesterol goes down by 40 points. Yes, they improve their thyroid function if you do it safely and not just to lose weight, but to do it medically. But nobody's looking at the side effects of the regular medications like statins. And these cause ED for a lot of my patients. They cause an ability to obtain and maintain an erection. And it doesn't necessarily, most of the antidepressants cause the same problem. And so trying to find a true source of the problem fixing those things works much better than just covering up the symptoms.
Absolutely. Thank you, Dr. Sulin. Dr. Neelima.
I agree with both Dr. Vicky and Dr. Sulin. One of the difficulties I face in India is this concept of, oh, we want medicines that have no side effects. We've heard about sexual side effects, but the fact is that if your medicine has no side effects, most likely it doesn't have any effects either. So that's a difficult one to get your head around. And one of the problems I have as a physician, when I'm treating conditions that I know a medicine can fix, and I'm not saying it's the first line of approach. Yes, you would look after somebody's physical needs, emotional needs, relational needs, and then you'd identify the patient who would benefit with a particular kind of medication. One of the difficulties I face, particularly in practice in India, is that there's a lot of doctor shopping, physician shopping going. So even if I know that a particular medicine will help somebody, they may choose to go ahead with the no side effects medicine. And unfortunately, what happens is that they lose time. Like this couple I told you about, the cancer lady. She needed vaginal estrogen very early on in her treatment, but she was too afraid to tell her doctor that they wanted to be sexual. The doctor just assumed that they didn't have a role of sexuality or sexual function in their relationship because, oh, we kept her alive. Then vaginal estrogen didn't work. So she's gone down a route of putting all sorts of things on her vulva and vagina with absolutely no effect at all. And she's missed out on getting important treatment. And that's time important. But we know, especially with menopause, that the shortening and shrinking of the vagina is progressive. It is inexorable. It will not reverse if it is not treated on time. So vaginal estrogen, I know in the coming years, not prescribing vaginal estrogen is going to amount to negligence because there is a window of opportunity where prescribing vaginal estrogen, using a sex toy, being sexually active actually keeps the vagina well lubricated, functional. It allows the pelvic floor muscle to retain some of its strength. It postpones or delays the occurrence of incontinence, prolapse, and many of the problems we know that we don't want to experience in old age. And the time that we lose by not doing that, I know from personal experience, say I ignore my HRT, I don't use my vaginal estrogen. It doesn't take long for the burning, pain, stinging to come back. It's that quick as you age. So losing that window of opportunity is very critical for women, and they don't understand it. And neither do a lot of clinicians. Even today, I have so many students in gynecology, so many colleagues in gynecology who hesitate to prescribe vaginal estrogen for their regular patients. Oh, no, we'll wait until she gets a problem. It might be too late. It just, your vagina, a dried out, flat vagina just does not stretch, even if you give it estrogen, if it's beyond that time where you've not been able to maintain its flexibility.
Thank you. This is so interesting. And we've had a number of questions in the chat relating to orgasm. So let's jump in to talking about orgasm specifically. As we age, or if somebody is in perimenopause or menopause or postmenopause, and I'm just referring to some notes on the side here, some women find it more difficult to orgasm, or their orgasms are less intense. Let's talk about some solutions for that. Not necessarily why, but let's talk about some solutions as we wrap up the end of this fascinating conversation. Dr. Neelima, jump in, please.
Aha, this is my favorite topic. So one thing that I like to teach both women and my students is that women have the capacity to build orgasmic platforms. So they have access to their memories, to resources that allow themselves to engage with aspects of becoming orgasmic, that they don't need to wait for a sexual encounter to actually become orgasmic. So building on giving yourself permission to step into your body, to actually enjoy the food you eat, to enjoy the massage, to enjoy being sensual is key to then enjoying sexual intimacy and then becoming orgasmic. And actually understanding, yes, using a sex toy, becoming orgasmic with masturbation, and actually enjoying physicality, exercise, um, using vaginal estrogen, using sex toys appropriately. All of this stuff can help you build your orgasmic platforms. Having a storybook. We learn about that. Having your story, your book of stories. So being important. Being intentional about remembering orgasmic events and not just sexual orgasm, but other orgasmic events can be key to developing platforms for developing orgasms when you're in a sexual encounter. And then not forgetting intimacy is actually a continuum. It doesn't just start when you enter the bedroom.
Thank you. Dr. Dr. Vicky, sorry.
Well, this is going to sound like an odd statement, but there are women and men out there who don't realize that a woman's orgasm comes from her clitoris. And they go, it comes from where? What's a clitoris? And they have no clue what a clitoris is, where it is, and what do you do with it? It's like, okay, it's there. So what do I do? And it's almost an anatomy lesson, number one, but then it's letting people know that it has to be something that also is nourished. So in other words, with our loss of estradiol in our menopausal years and many times late perimenopausal years, it's not about putting estradiol onto a clitoris. I had women who would tell me they did that, and I would say, oh my Lord, how many hours at work did you have an orgasm that distracted you from being able to actually function at work? And they would look down and say, oh my gosh, it took 4 hours to go away. Well, obviously, direct estradiol to
I
the
could take a
clitoris,
4-hour orgasm. That'd be good.
not a good idea. So I would say to a patient, external at the base and allow the blood flow to pick it up and take it to the clitoris. Then you can do some external stimulation to a clitoris. You can have your partner do the external stimulation to a clitoris. In women who have some extra weight in that area, it may take exposing that hidden clitoris so that they truly can realize, oh, that's where it is, because they may actually have it get lost in skin folds. And and that sounds funny, but it's for some women a reality. But it's their understanding of where is their orgasm coming from. And many are too embarrassed to say that they have never had orgasm or that they seek orgasm on their own, like a self-masturbation kind of exercise. And they're embarrassed to say it because they think it will go against their culture or their religion or against their husband, that they're being somehow indulging in self-pleasure where that isn't what they should be doing. And there are many taboos that people put upon themselves, that society, their religion puts upon them, but it's the basic understanding of the anatomy of here is where your clitoris is, this is where your orgasm comes from. And just understanding, yes, you can apply some external estradiol cream, but don't do it directly. Do it at the base and use a little bit first. Wean up little by little until you find the amount that works for you.
Oh, wow. Thank you. And Dr. Sue Lin, so I know one of the focuses on the question is how do we increase our orgasmic pleasure as we age? And we've addressed some of that. So let's go along the lines, and maybe if any of you know about the O shot and what your thoughts are. The O shot.
Yes, I actually do the O shot. And that's what I was going to tell. There's two parts to orgasm. There's chemical and then there's physical. And so, as she said, with religious programming and social taboos, people think, oh, no, I'm not supposed to feel that way. The thoughts and actions that transport you to ecstasy, though. But physically, the O shot, basically, we draw blood. We spin it, we take off the serum, and the white cells and red cells stay below, and we inject it into the clitoris. What that does is increases blood flow to the organ, and it actually stimulates sensitivity. Now, yes, it does hurt a little bit when I block it with lidocaine first, but then after that, most women are ecstatic about the orgasm, but many women don't realize they can't orgasm vaginally. Some people actually can only orgasm clitorally, or, and I'm going to go there, anally. Because when I do a rectal exam on men and I stimulate their prostate, when we do even rectal on women and we stimulate even their Skene's gland, which is similar to the prostate, they can get increased blood flow to that area, increased nerve stimulation, and they can actually have an orgasm that way, which I don't know. This is all medical, not personal experience. But the other component to it is oxytocin is released, right? When that's the love hormone that gives pleasure in your moments of physical intimacy. And that emotional communication can make people really get to a heightened state of orgasm. Even data recommended for men not to get to that orgasm, to hold and to make the stimulation go into their spine to get that feeling of ecstasy before just getting ejaculation, because part of the orgasm is just in the feeling and the emotional component to it, as well as the trigger or release of dopamine, which is the reward chemical, which makes you enhance happiness. You get motivated. You're happy with this reinforcement loop of, oh, I feel so good with that. So then I do more of that. And so the physical plus the chemical component together is amazing.
Thank you, Dr. Sue Lin. And I just want to point out, my Bill is also a painter, and these are pictures of vulva spine. So you
Really?
know where the clitoris is.
Ah,
There's a
that's
little, isn't
awesome.
great? Looks like flowers, but it's actually
That is
just a
awesome.
really big one. But he has a series of them. But anyway, fabulous discussion, Dr. Neelam. I have a feeling you have something to add to this.
There was some research done on what we call an extended sensory orgasm. So actually, women, they need to educate their partners that their whole body is designed for sensual pleasure, not just the genitals. Whereas men's sensual pleasure is really, really focused around the genitals, around the penis. But in women, all of the external, extra genital sites are contributing to becoming orgasmic. So the side, all the erogenous zones, like the side of the neck, the ears, the breast, nipple, side of the waist, the inside of the arms, the armpits, the lower back, the inner thighs, behind the knees, even tickling toes. So all of these things, touch in women's orgasmic capacity, if you're not using touch all over the body, not just the genitals, not just the clitoris, then you're kind of losing out on a big component of that woman's orgasmic capacity.
Absolutely. Now let's comment on, and I know we're coming to the end of our time, so if somebody has to leave, thank you so much for being here. We're going to keep going because there are some more things we need to discuss, but if you need to leave, we totally understand. How would you help a woman or man feel more desire and more desirable after either menopause for women or andropause for men? No matter what your state of weight or physical appearance, how do you help somebody feel more desirable? Dr. Vicky.
Well, desirability is a subjective term, and everybody feels desirability in a different way. Many times we tie it to the physicality of what we look like. And our physicality, of course, is tied to our dietary habits, our exercise habits. It ties to the clothes that we decide that we're going to wear. It ties to many things, the relationships with our kids, if they're out of the house now, and to your grandchildren. It applies to whether you feel you have enough worth in your daily activities. What is your job capacity? Are you happy at your job? Are you feeling underdeserved at your job? What do you do when you come home in the evening? In other words, desirability and what we do with how we feel about approaching sex is very tied to our spiritual, our mental, and our physical. And so we truly have to be feeling good. And Dr. Sulin and Dr. Neelama have both said it. It's mind, body, spirit, not in those words, but we have to be balanced in all of those areas, or we may feel that we just truly don't deserve that that ability to have a sexual health. We don't feel that we can honor it. We don't feel that that's part of what we can do. And so it's important to just be mindful that you bring to the table where you are. Are you balanced in mind, body, spirit, or not? And if you're not, you may have a little work to do in those areas in order to gain that balance. And it may be you can do it yourself. You may need to do it with your partner, with your kids. You may need to actually work with somebody outside, like a counselor or your doctor. But there's no shame in that.
Yeah.
The fact that you cannot find that balance yourself, there's a lot of people out there who struggle with that very issue and don't even realize that that's their issue.
Thank you, Dr. Vicky. Dr. Sue Lin.
Yeah, I agree. Our minds have so much power and potential to bring us to a heightened state of awareness of our physical body, and our body's ability or sexuality is the seat of our creativity, right? So, our ability to raise our desirability quotient is what I say hygiene is.
Mm.
Because some people may not do grooming, or they may, they can use baking soda or charcoal, or a freshly showered body is always good. But pheromones are erotic. Some people like when somebody just got sweaty at the gym and then got, sensual as a result of that. But that can be a game changer for others. So you kind of almost need to know your partner's erotic blueprint. And then you're also your partner's love language. What do they like? Do they like to be soft or rough, or, kinky or sexy, or, navigating these little things are very important. There's even a hygiene for men now called Ballsy. I'm advertising for them actually, but I don't get any rewards, don't worry. And some men don't realize that actually can help them, women be more attracted to them, in some way. But our mind is a big component to our sexuality.
Thank you, Dr. Sue Lin. Dr. Neelima, and you're muted again.
Yes, because it's Diwali and the firecrackers are
Yeah,
still going on.
we can't hear it. It's all good.
I totally love what Dr. Vicky and Dr. Sulan have said. One thing I notice particularly is the investment we make in our health, in our physical fitness, because we know people who are physically fit have better clitoral and penile blood flow. So your aerobic fitness, your metabolic fitness, your ability to switch between sugar burning, fat burning, your neural fitness, your autonomic nervous system. How good is it in shifting between parasympathetic and sympathetic? Parasympathetics are rest and digest, and sympathetic is the ability to deal with challenges. How quickly can you switch from one to the other? That fitness level is really key to the blood flow. And vascularity is essential for optimal sexual response, both in men and women. And if you have an impaired vascular system, impaired vascular response, then your body just doesn't respond how you want it to. It loses its predictability. And when it loses its predictability and reliability, you tend to lose your confidence sexually. So in order to be desirable and improve our desirability, when we improve our physical and mental fitness, we more than likely improve our sexual fitness. When we improve our sexual fitness, we improve our sexual confidence. And when our sexual confidence goes up, our self-esteem goes up, and how we show up in relationships improves. And then we're much more likely to invest in other skills like improving negotiation, conversations, being much more able to commit to solving relationship issues without fighting or blaming or shaming or guilting the other person. So when we don't feel threatened, then we're much more likely to be compassionate and kind with each other. So the key to not feeling threatened and always under stress is to actually get fit. So get physically, mentally, spiritually, psychologically fit, and you'll find that your sexual relationships improve.
Thank you. We've been talking a lot about taking personal responsibility for our own body, mind, spirit, and as we engage in sexual intimacy with with a partner, that we are responsible for ourselves. If we don't have a partner, let's get really clear and specific. And as we age, what are some things that you would recommend for somebody who is either single or is not in a sexual relationship, even if they do have a partner? What are some things that you would say, this is key, absolutely critical? Dr. Nima.
I'd go back to this fitness thing because how we feel within our bodies really, really makes a big difference to how we show up. So feeling good about ourselves, physically, mentally, psychologically, is important. Sexually, particularly for women, making sure their vaginal health is good, getting vaginal estrogen as they age. If they're not able to be in an intimate partner relationship to have intercourse, then using sex toys, the vaginal sex toys, not because I have women who only use clitoral toys. But what they need is something that actually allows their pelvic floor muscles to contract and relax around the sex toy. And actually, it can take a little bit of time to find one that suits you. So putting that effort in and not being ashamed to ask for what you want, and um, learning to practice with it. Because I have this woman say, "How long did you use the sex?" Oh, I tried for 3 or 4 minutes. It doesn't suit me. So understanding your body and saying, "Well, 3 or 4 minutes is just too short. You more likely need 30 minutes." She says, "What? 30 minutes?" But everybody will know I'm using the toy, so you get a better toy. Find one with a remote control. So just being little bit more mischievous and experimental, and actually going out there, looking at different sites and choosing one that suits you, and maybe having a multiple, having more than one. Or maybe you're using something that's now got artificial intelligence, like the Lioness. Invest in yourself. Actually learn what clicks, what works for you, and then use it regularly. We know that the clitoris needs to be stimulated at least once every couple of weeks to be able to maintain its vascularity, to stop the hood from crusting over, from shrinking and becoming atrophic. So that's the recommended frequency of stimulating the clitoris to make sure it retains its vascularity. So that's the important thing. Because it's all about vasculature, it's all about maintaining blood flow.
So get fit, whatever that means to you. So thank you. Dr. Sue Lin, what would you add to that?
Actually, I'm very, very, I'm going to give a little story about my 75-year-old lady who decided that she wanted to lose weight. So she had some insulin resistance. We gave her semaglutide and she lost like 20 pounds. And I was interested because she's single and not sexually active. And I wanted to know why she wanted to lose. She goes, I wanted to feel good about myself. And I thought, wow, that was all that she wanted. However, after she lost weight, then she wanted to do the Mona Lisa for her vaginal health to improve her blood flow to the vagina because she would have some stress incontinence and some urge incontinence and some irritation vaginally. And we started on estriol vaginal cream. And then I gave her pelvic floor muscle rehabilitation, and her stress incontinence improved, her urge incontinence improved. She felt better about herself, and now she has a boyfriend. So, so there, it's so funny that you think that you're doing it just for yourself. And then when you feel so good about yourself, then you can share with others.
Fantastic. Thank you. Dr. Vicky.
Well, and I'm going to echo on that same theme, but from a slightly different perspective. There are a lot of people out there that are single because they went through divorce, or they are widowed or widower, and they have lost the love of their life, and they feel that they cannot recapture what they had, and that why bother looking. And so part of it is strongly psychological because they just mourn, if you will, and continue to mourn love lost, and that will never be recaptured. And I think that's part of the appeal to one of the current long-running shows, The Bachelorette, or The Golden Bachelorette, or whatever that runs in American television about looking for new love. And so that aspect of people out there is a pretty large aspect of people, and they have different religious overlays. They have different family, like children who may feel you can't cheat on dad even though he's dead. Well, wait a minute. Why can't we talk about what's good for mom instead of you're blowing the image of what you want to keep as a child of mom and dad, even though that image is long gone, that train has left the station. So there are a lot of pressures that are put on women for the various reasons that they are in a single and situation where they might have to deal with something like weight loss or change their diet, or they need to lose weight, or what is their motivation to do that if their children are not going to be happy with them and they're going to cause trouble in the family or whatever. So I think that we tend to forget as well that when we treat a patient, we're treating their environment, and we're treating everybody that they are encountering in their day, in their week. And grown children and what the relationships they have with other family members is a really strong aspect of it. And I remember I had a patient come to me. She had been widowed for only 3 or 4 years, and there was a very strong relationship, and she was considering getting remarried. And she came to my office and asked me, "Well, what do you think? Is this cheating on my husband?" Was the first question she asked. And one of my sons is unhappy with me and might disown me. And I'm like, wait a minute, he can't disown you, you bore him. But kids can be very um vocal about their preferences, and they think that they have the ability to control this older woman, their mom, because she's old and frail and needs my guidance. Well, she may not be as old and frail as you think. And so the upshot is she wanted to be examined to make sure she could handle intercourse. She wanted to make sure that there wouldn't be any tearing of her vaginal vault, that she could actually do intercourse. And that just sounds like a funny phrase to say. Am I okay to do this? Um, and then they ended up getting married, and there was still family strife amongst family members, but they learned to work through it. And so part of it is stuff we can't always predict, but we have to live with, which is other family and community.
Fantastic. I'm going to ask two really quick questions, and maybe just by show of hand, which practitioner wants to answer them. The first one is, if we're on bioidentical hormones or hormones, can someone use a vaginal estrogen ring? Who? Go ahead, Vicky.
Oh, absolutely. Because many times an estrogen ring is going to deliver regionally to the vagina alone, which is why and there'll be minimal pickup to the rest of the body, but it's why a breast cancer patient can indeed have a vaginal estrogen ring treatment and still be undergoing breast cancer treatment. So it doesn't preclude that you can actually use that type of a localized treatment. But systemic bioidentical therapy, whether it's by oral, whether it's by topical, whether it's by a patch covered by your insurance, whether it's by oral liquid. There are many varieties of how we get bioidentical hormone back into us. It's hard to get it with enough food because you have to eat just a truckload of yams in order to get enough progesterone, and it has to be the right kind of soy, which is not really available in the US, to give enough estradiol to women. But there are too many foods that are anti-estrogenic, or they're putting estrogen in the meats, and we're getting, and we won't even go down that road. But there are, yes, can you take bioidentical hormone replacement, measure it by blood levels, see where you are? Absolutely. Can you also use a vaginal ring at the same time? Yes.
Okay, great. Thank you. And another question, unless somebody else has something urgent to add? No? Okay. The jade egg. Any comments about the jade egg as a sex toy or as a tool? No? Okay. That question does not get answered. Any final word? Oh, go ahead, Dr. Neelima.
And one of the things I learned recently, and this is from a talk on the neurobiology and anatomy of the clitoris. is that the clitoris nerve endings actually respond differently in different women, but they found now that its sensitivity to pressure is almost 75 to 80% compared to just stimulation. So pressure over the mons pubis and the clitoris and around the clitoris actually lends itself to more stimulation, especially the dorsal part, which is the upper part of the clitoris where the most concentration of nerve endings is. So then it lends itself to, the toys that you use in the palm of your hand, which you can exert pressure with, that rest on the clitoris and you can push down, actually create a much more intense experience of orgasm than just the devices that suck on the clitoris.
Okay,
Because there's so many different types.
there you go. There are so many sex toys, and what I'm hearing is explore, play. It's important whether you have a partner or not. Really, really, really important to be active in this area of our lives because it is a part of our whole being, and it's important not to let that go. Any final words for our beautiful audience today from you? How would you like to leave this conversation, Dr. Sulin?
I've been thrilled and enjoyed this time together. And I'm really happy to be able to provide information for patients. I see patients on telehealth, even though I'm in Arizona. I can actually help with patients with testosterone clinics. I can help them in regards to bioidentical hormones, in regards to weight loss with semaglutide, and at Quantum Health and Wellness Center, which would be quantumhealthmhk.com. You can reach out to us, and we are so willing to help. I actually also do urology consults, even with my quantum office, because I'm not practicing academic medicine anymore at the University of Arizona. And so now, and I'm not practicing urology in St. Thomas. I was covering for someone for a while, but I'm actually doing consults because a lot of time our doctors, unfortunately, don't have enough time in their office to visit. And so I can actually spend an hour with a patient to explain about their prostate cancer. And I think in regards to just even females having questions, we do free consults. Some women don't even know they have a problem in regards to their sexual health. And so I'll do free consults to educate people about stress and cortisol and estrogen and progesterone and testosterone and all the things made not just in the ovaries and testes, but also in the adrenal gland. And so I'm really glad that I'm able to expose what we can do for people because some people don't know and they're afraid to ask. When they go to the doctor's office, it's so fast that they don't get a chance to ask everything they need. So I'm available at Quantum Health Wellness Center to help with anyone who has questions.
Thank you so much. And Dr. Vicky, just before you go, we are in January, we're going to switch things up a little bit. And with Dr. Vicky and Dr. Melissa, we are going to have a book club, and that will lead into what you're going to talk about, Dr. Vicky. It will be 8 weeks. It will be on Wednesday evenings in North America time. And stay tuned. There will be more information coming about that. And it will be all about, over to you, Vicky.
It'll be about full bloom. This is one of the books that I wrote, and I wrote it for the patient because it's something that patients have to have a comfort level and an understanding because many times their doctors don't have this training and they don't know how to help their patients through hormone sawtooth time and through menopause. They just tell them the curse is gone. So I go through the myths and the truths, and I go through where the graphs are for age appropriate hormone levels. I go through the American versus the European research. I go through a number of case studies, and by decades, by the 40s, women in their 50s, women in their 60s, they all present differently. Women in their 70s, even in their 80s. And then a chapter in how to talk to your doctor. Wow. So I give them the list of labs that they should walk in and say, I really want these labs to be done, and here's why. These are the symptoms I have. I put that symptom worksheet in here so that they can actually fill it out themselves. So we're going to run through this on an online book club and give women their voice. Give them the knowledge that they can actually confidently walk into their doctor and have a conversation and be interactive with their doctor and actually help them understand this is what I'm feeling.
Thank you, Dr. Vicky and Dr. Neelima. And I've put all the contact information for our beautiful practitioners in the chat as well. Dr. Neelima, how would you like to leave people? And how would they get in touch with you other than our listing?
Um, I really want women to understand that becoming orgasmic is not as difficult as it seems to be. Uh, Health, wellness, physical fitness, mental fitness is really key to becoming orgasmic. And becoming orgasmic can save your life, because if you're not, you need to get all that stuff checked out. I'm currently running the menopause track alongside WildFit, which is a program with Eric Ed Meets, addressing nutrition, food psychology, and nutritional anthropology. And we also look at menopause, even the evolution of menopause and anthropology around menopause, and how nutrition can actually help reverse symptoms relating to menopause, build better bone health as we age, better oral health, better gut health as we age, and therefore better mental health. In that track, I address a lot of myths around exercise, well-being, different kinds of psychological and urogenital problems and sexual problems. So most welcome to join that track. I think the next cohort begins at the end of January. It'll be on the WildFit site.
Fantastic. I have a couple of quotes. Before I get there, I have two requests. One, if you have appreciated this, please sign up for our monthly Mindful Moment newsletter. We will only send it once a month, and then we do event reminders before we get to our events. We'd love for you to stay in touch with us. And what you do is on the Mind Myself website, just scroll down until you see sign up for our newsletter, Monthly Mindful Moment here. That's it. We'd love for you to stay in touch with us. And if you have a testimonial because you've had a great experience at this event or another event, that would be amazing. We would love it. And you could just send it to my email address, esther@mindmyself.com. That would be fantastic. And just before we leave, Helen Mirren says, a woman becomes sexier when she becomes more confident, when she knows who she is. That's what makes a woman beautiful. I love that. And that was a long time ago, 2008, in an interview with her. And Emma Thompson, the inimitable Emma Thompson, says, I think women need to know that they have the power to reclaim their bodies, their desires, and their needs. It's never too late. Thank you for joining us today, you and the audience and the practitioners. Thank you so much for contributing
I
your
have
beauty.
I have one thing,
Go
if you
ahead.
don't mind,
Go
Holly.
ahead.
I want to give a shout out to Rusty, who's been my editor in my upcoming book, How to Get Ahead. And she has been amazing. And it's about male sexual health, but it's all for women, actually. So it's all good.
Fantastic. And thank you. Yeah, Rusty is a fabulous editor. And if you're ever thinking of writing anything, she has writing groups and they're a fantastic resource. Please connect with our practitioners. They have such wisdom to share, as you've heard today, and you can have personal consults. So visit the website, visit their links, and thank you for being here. We do this because you matter.